Thank you, Bob. I'm conscious I've got 4 minutes to get through this, so I won't hold you up too much for lunch. So I was just asked to give a bit of a background about our area. So I'm just going to talk, I'll just skip that. So this is our area. We're in the top right-hand corner of it, or left-hand corner, depends where you look at the map. And it's quite a large region covering almost down, you can see Melbourne from the bottom, and you're right on the top of the state on the other side. So I thought I'd just start by just contrasting what a patient that in our region has to experience to have care compared to someone who presents to some of the metropolitan hospitals I've worked at in the last 3 years. So someone that lives within 5 to 10 kilometres of a major hospital might have dysphagia. They'll get an endoscopy, shows they've got gastric cancer. They can usually have most of their tests done at the same institution, and the multidisciplinary meeting will also happen there as well, where they can access all of the test results, and then they'll have treatment. So this is in our region. Bendigo is at the bottom here, so I've only just used part of it here. So we have a patient that lives in Kahuna, 2,500 population, but probably has the most capable GP in the state. This person has dysphagia, gets sent to the nearest spot where they can have an endoscopy. They can actually do some in Kahuna, but they wanted one that with a bit more surgical expertise here. So that's about a 65k round trip. So they've travelled 130 kilometres. They might have to double that to come back another day to have a talk about what that means. Their pathology leaves the region, so we'll go down to Melbourne. That's not the right direction to Melbourne, that's out of the area. They'll get presented an MDM in Bendigo remotely. And then the patient will have to come down to Bendigo to have their investigations done, particularly if they've got a PET scan or CT scan at the same time. They'll go back home. If we're really lucky, we'll coordinate their surgical appointment and a medical oncology appointment on the same day. We don't always manage to do that. So by this stage, by the time they return home, they've done over 500 kilometres, and there's been a lot of time driving as well. We often give the first dose of chemo. For example, this was gastric cancer, we might give FLOT, and we're worried about the risk of reaction, so we might give the first cycle in Bendigo rather than a regional site, and so they've come back down another time. After that, finally, the patient can have chemotherapy 30 kilometres down the road, 20 minutes from home in Kerrang for the rest of their care. So, unfortunately, though, they might develop febrile neutropenia, and a lot of the GPs in Kerrang are excellent, but if they get sick, they'll have to come back down to Bendigo again, and then they'll go back home, and then they'll eventually come back down to Bendigo for their surgery, and then back to Kerrang for chemotherapy. They may need a restaging CT scan, and they'll probably have that done at Swan Hill because our parking costs $8 a day, so patients object to that. They won't be able to find a park right at the front of the hospital. And the Swan Hill CTs, the closest for Kahuna is either Echuca or Swan Hill, but Swan Hill are our radiologists from Bendigo, and so some of our patients prefer to go there because they get the same people reporting their scans. So they'll come back. So by the time they've had treatment, that's over 2,000 kilometres if we've been vaguely efficient at trying to help manage their care. And that doesn't take into account all the people that present to Echuca and then decide they want to go down to Melbourne for care, whether to one of the metropolitan hospitals as well. So there's a lot of barriers to care that people have just in terms of trying to navigate their areas, let alone all the different health networks, which all have different medical records that don't talk to each other. So I'm just going to show you what we do in our region here. I've basically cut a line through our region at the top because we don't have a lot to do with the Mildura part. They run that area of the state. But the home at the bottom is where we work in a Bendigo-centric area. We provide clinics at Kerrang. We have oncologists that go to Echuca, who are their own entity, and we also go to Kyneton as well. We can provide chemotherapy in Swan Hill, Kerrang, Echuca. Kyabram isn't part of us. Shepparton goes off to do Kyabram. And even though Bendigo is a hub for the area, we are also our own little spoke of a bigger hub in terms of some of our haematology care where people come down to Peter Mac for treatment as well. So there is quite a lot of travel that people have in our area. In terms of the numbers, I think if you look at the number of people on chairs in Bendigo in particular, we're often similar to what you'd see at some of the major metropolitan sites. When you look at some of the numbers down the bottom where we have a fortnightly clinic to Kerrang, but actually it's a low number of treatment there, this doesn't take into account oral treatments, but geographically we can't get to everywhere in the region. So sometimes where we go to doesn't necessarily make logistical sense from a population point of view, but it's as close as we can get. So we have a fortnightly clinic in Kerrang, which has 1 clerical staff, 2 doctors, and a nurse practitioner on the alternate clinics. In Echuca, there's an oncologist there every week, and there's 2 oncologists every second week, and we basically incorporate in part of their usual practice there. And in Kyneton, we have a 2-doctor clinic, which has a medical oncologist and a radiation oncologist and clerical staff as well. So there are a number of challenges that we face when we're trying to administer chemotherapy safely, and this is by no means all of them. From a start, you've got to get accredited, and all of the sites are very proud of their own hospital, so you have to get accredited at each hospital, and there's no reciprocal arrangement between any of the providers. We have to decide which regimens you can deliver locally or which ones need to come to a larger site. Basically, if there's 3 syllables or more, it probably won't be delivered regionally. The other practicalities, ones that have hypersensitivity reactions, such as rituximab or taxanes, we often will do the first dose at a larger site or do it at a site when we're on site there as well, with the exception of Echuca, where they're happy to do things. Writing of chemotherapy orders, Bob, you can block your ears there, it's all paper-based. And there's been no uniform strategy, but we all use the same paper chart. It's happened by accident rather than design, but it probably does help minimise some errors because we're using the same paperwork. Delivering medication to sites is a challenge. So 3 of the sites we go to provide chemotherapy have a hospital pharmacy, but one of them has a community pharmacy. And so that has different requirements when you're administering chemotherapy. Financial reimbursement's a problem. So I think the Monash system that was discussed earlier is a fantastic system. I think being able to do subcutaneous bortezomib and all that kind of stuff at home would be really great service. We struggle in our regional sites to do a lot of the subcutaneous medications because there's no funding. And when you're running a large centre, you can sort of incorporate this, but when you've got somewhere where it's only doing chemotherapy 2 or 3 days a week, if they're using up a chair and not getting any money for that, that can be a problem. IV access can also be a problem, so for those that need ports or PICs, ports can be done in Bendigo or Echuca, but not elsewhere. PIC lines can also be done there as well, so people are travelling to have just access device. So these are all challenges people have before they've actually sat in a chair and actually had any chemotherapy. Once you start having chemotherapy, it's really important that the nurses feel supported on the ground because most of the time we're not there. We might be there once a fortnight or once a week. And so you've got to have quick ways of communicating, and that there's no real formal way that that's done really. We have phone calls, we get emails, but that occurs in the context of your normal working day in other sites as well. Patient support on discharge is always a problem, and care of the unwell patient can be difficult when people are presenting to places where they're having specialised treatment and presenting to very generalised emergency departments. Support for nursing education is challenging, and a lot of the nurses do find difficulty in getting time to have education and also get support from larger centres. We do have some support for doing that through our Kerrang clinic, where our nurse practitioner can come up and help assist with treatment. And Echuca is a larger centre and they do a lot of that in-house, but particularly in Swan Hill, which is the furthest area we have, it's hard to provide as much on-the-ground support. Covering sick staff is really difficult. So our sick policy at one of the regional sites, when we asked the solo practitioner what she would do if she was sick, was that she put a mask on and suck it up. But there's no contingency plan at the moment. If she was sick, we don't have anyone else that could do chemotherapy there. The benefits, obviously, with all of this is we're trying to ultimately have people achieving care closer to home. I think that as a medical practitioner, I have a much better relationship with local practitioners in the smaller areas because we rely on them day to day to look after people when they're sick. And I think we have quicker pathways than I would with some of the people that I look after in Bendigo. I've also got a much better understanding about what the local health service can do by going out to this area. So if someone turns up to emergency, who is fine to stay in the area and who needs to come down to somewhere larger. I think it does upskill not only nurses in the wards of these hospitals, but also the local practitioners as well when you're there a bit more often. And it does provide a lot of variety in clinical practice, whereas in the city you're often looking at a very subspecialty focus. There are a number of things that we're trying to do to try and improve things in the region. So at the moment, from Bendigo, we're looking at trying to have a more formalised agreement with the places where we do chemotherapy about what treatments we can do when, what is needed to be safe, what type of education is needed as well there. And that will also have benefits down the track if you're going to set up a new site. And I think a lot of that will probably tie in with the COSA recommendations as well. There is projects looking about how we can tie regional patients when they come from the city or go to the city about trying to improve that communication flow, which is poor at the moment. Telehealth, you have to mention any time you mention regional practice. It's a sexy topic right now. I think that there will always be a role for telehealth, but I think people are always going to want to see someone face-to-face at some stage. I think you do still need to have people going out at least occasionally to provide some support there. So I mean, my conclusion really is that if you're trying to run a hub and spoke or a place where you're a visiting oncologist to a regional area, you really do require a lot of flexibility and generosity of spirit from both sides, because we acknowledge that that distance does mean there's difficulty at times. Most of these arrangements, I suspect it's the same in the rest of the state, have formed rather organically rather than a strategic implementation about how things are going to grow over 20 years. So developing templates on minimum requirements, I think, will help improve the care in these areas in the future. For me, it's a rewarding part of my clinical practice, and the other oncologists in town that do it as well find it a very good part of their clinical practice, but it certainly does take time and effort. Thank you.
Thanks very much, Robert. That's a really wake-up call about what actually it is like out there for patients and practitioners to deliver cancer care. Questions? So one of the things is hub and spoke. You mentioned the last thing. There's a glib saying about that. Everybody wants to be a hub and no one wants to be a spoke. But what I do think as I look at what you're saying, and you've got Department of Health people here. I'm now not a member of the Department of Health, so I can say this. Essentially, you have to have a network, and it has to be resourced above and beyond what would be same requirement for something where everything's happening around Brunswick and Parkville. You know. So would you take that on board, please, Catherine? I think it's the only way it's going to be done. But I thought it was a fantastic presentation, and the whole issue for us is how we provide safe care, as we've said 1,000 times this morning, for people outside the main centres and, of course, within the main centres. And you've given us a real lead as to how we should go. So thank you very much.